We'll now move ahead with the penultimate speaker of the Congress, that is Dr. Sanjeev Rajapaksha, and he is currently the Assistant Professor of Cardiology at the Teaching Hospital in Anuradhapura from Sri Lanka. Dr. Rajapaksha joins us this afternoon for the next 11 minutes to speak on imaging in the assessment of dilated cardiomyopathy. If you're ready, Dr. Rajapaksha, the next 11 minutes are yours.
Good afternoon, chairpersons and ladies and gentlemen. At the outset, I want to make a small correction actually. I'm not an assistant professor. Anyway, the topic today I have got is regarding multimodality imaging in the assessment of dilated cardiomyopathy. You have heard a lot about cardiomyopathy and definition of cardiomyopathies. But when we talk about dilated cardiomyopathy, you will find left ventricular dilatation and left ventricular systolic dysfunction, and especially in the absence of abnormal loading conditions or extensive coronary artery disease. It's very important that we make accurate and reproducible assessment of cardiac dimensions and functions of the heart. And it's need to fully characterize the valve functions and the presence and functional consequence of coronary artery disease before we make a diagnosis of dilated cardiomyopathy. In that regard, it's because the coronary artery disease is considered the most frequent cause of finding a dilated and dysfunctional heart, as well as the chronic volume or pressure overload due to chronic valve disease can also cause dilatation of the left ventricle and dysfunction of the left ventricle. So multimodality cardiac imaging aims to correctly identify patients with dilated cardiomyopathy and identify from the other patients with dilated left ventricles. So these imaging modalities may contribute valuable information for reaching a probable diagnosis of acquired dilated cardiomyopathy. And ejection fraction is considered to be an important imaging measurement in these patients because it's diagnostic and prognostic relevance, and most of the clinical trials, the ejection fraction has been validated for the assessment. Although ejection fraction is calculated frequently, sometimes it's still a challenge for cardiovascular imaging. So when we talk about different modalities of imaging, the echocardiography, cardiac MR, cardiac CT, SPECT and PET are commonly used, and these last two actually SPECT and PET have been already discussed in the morning. The echocardiogram is the cornerstone of diagnostic imaging in dilated cardiomyopathy. Because the echocardiography is accurate and is widely available, and there is no ionizing radiation involved in this examination. And if you find a patient with low ejection fraction, less than 45%, with dilated left ventricle, which is more than 112% of the predicted value corrected for the age and body surface area, so you can come to a conclusion that is a dilated left ventricle. And you can use this modified Simpson's rule to calculate the ejection fraction. This is the imaging modality of choice for evaluating patients with heart failure in most of the trials, although it has wide inter and intra-observer measurement variability, and you might find some patients, obese patients with poor acoustic windows. You can use ultrasonographic contrast for cavity opacification which significantly improves the accuracy and reproducibility. And later on, the 3D echocardiography allows rapid and accurate reproducible LV measurements and left ventricular measurement, ejection fraction measurements. The other imaging modalities which are being used in this clinical scenario are cardiac MRI, which is considered to be the gold standard for accurate and reproducible assessment of left ventricular volumes and ejection fraction. Cardiac CT may be used, and CT may overestimate the left ventricular volumes and underestimate the ejection fraction compared to MR. I don't know if this is clear for you. This compares the different modalities of imaging, including 2D, 3D, cardiac MR, CT, SPECT and PET, where the LV volume, you can see The LV volume can easily be measured and with accuracy with cardiac MR, and valve diseases can be measured or diagnosed with 2D or 3D assessment. And likewise, there are limitations. I don't want to go through the whole list. This shows the panel A describes the 2D echocardiogram with the possibility of measuring ejection fraction. The B describes the speckle tracking, where you can use overall left ventricular function as well as the regional wall motion abnormalities can be assessed with this. The panel C shows the 3D assessment or live 3D assessment of left ventricle, where you can get a more reliable left ventricular volume measurements and ejection fraction measurements. The panel D describes the CT, where the echo is not reliable enough in difficult patients. You can use this method, but overall, or after all, the cardiac MRI, which is shown in panel E, actually is the gold standard and very accurate method of measuring the LV volume and ejection fraction. Other than the morphology assessment, we need to identify the etiology of these patients, why these patients has developed dilated cardiomyopathy. And it's critical to exclude valvular disease and severe coronary artery disease I have described earlier. So transthoracic echocardiography is the standard tool in this situation. You may go for transesophageal echo to improve the diagnostic accuracy in some patients. Cardiac MRI, as I described, is a reasonable alternative which provides qualitative and quantitative measurements of valve stenosis and regurgitation in addition to volume assessment. So coronary angiogram, we may have to go for angiogram, which is recommended in the assessment of dilated cardiomyopathy, particularly in patients who have angina or considered to be high risk for ischemic heart disease. Cardiac CT can allow the detection of significant stenosis, as we discussed earlier in this conference, with a very high negative predictive value, especially in patients who are having a low or intermediate risk of ischemic heart disease. Late gadolinium enhancement cardiac MRI is a powerful technique to distinguish systolic dysfunction related to coronary artery disease. And the combination of this late gadolinium enhancements, MR and CT angiography can effectively and uninvasively exclude the possibility of underlying ischemia causing dilated left ventricle. Dobutamine stress echocardiogram is also available, which can detect coronary artery disease in these patients, but sometimes if in the presence of left bundle branch block and ECG, the wall motion abnormalities may be difficult to interpret. This basically summarizes what I have told you. When you get a patient after history and physical examination and ECG, we do a proper transthoracic echocardiogram with or without transesophageal echo and detect whether there is significant valvular disease. If not, so we need to identify whether they are high risk or low risk for ischemic heart disease. So if the ischemic heart disease risk is high, then straight away we can send the patient for cardiac catheterization, which will confirm or exclude underlying ischemic cardiomyopathy. Or otherwise, they can go for coronary CT. So cardiac MRI imaging is currently considered the most accurate and invasive diagnostic test for myocarditis, which is another cause of dilated cardiomyopathy, which can give rise to different patterns. This describes the first transmural late gadolinium enhancement, which is typically seen in transmural infarct in ischemic dilated cardiomyopathy, but also in patients with sarcoidosis and patchy myocarditis. Subendocardial LGE, which you can get in subendocardial infarct in ischemic dilated cardiomyopathy, in addition to the other patients like sarcoidosis or myocarditis. The global subendocardial LGE, gadolinium late enhancement, you can get in amyloidosis. Epicardial LGE you see in patients with sarcoidosis and in some infiltrative cardiomyopathies. In myocarditis, idiopathic dilated cardiomyopathy can give rise to what is called mid-wall late gadolinium enhancement. And sometimes you won't see any gadolinium enhancement in patients with stress cardiomyopathy like Takotsubo or peripartum cardiomyopathy, and some patients with idiopathic cardiomyopathy. So this one shows, the panel A shows increased enhancement in the T2 weighted cardiac MRI, and with late gadolinium enhancement, especially the epicardial involvement in a patient with myocarditis with a small patch of non-involved normal myocardium, which is in the mid-lateral wall. We can use speckle tracking in echocardiography, where there will be deformation of the longitudinal contractions, which is confirmed on MRI in the panel D. So in addition to this, you need to determine the prognosis. The transthoracic echocardiogram, which can give rise to give us several prognostic tools like measuring LA volume or RA volume, LV diastolic function or pulmonary arterial pressure, and we can calculate different indices actually. So this have been proven in the clinical trials to predict the mortality in these patients. In addition, we can use tissue Doppler imaging with mitral annular velocity, which give rise to details about the mortality risk. So it can give rise to prognosis. So I will skip this one. In addition to the prognosis, this can be used to guide the device therapy. You know, in about 1/3 of the patients who get CRT done in these patients, their symptoms will not improve. I mean, can we identify these patients by doing a different type of imaging? Small studies have shown yes, but major studies like Prospect has shown that there's no recommended criteria. So this one shows actually there's no single echocardiogram measure of disc synchrony which can be recommended to improve patient selection before CRT. And the patients who have ICD devices, actually some patients, they will never get ICD appropriate therapy. So can we identify these patients who actually do not need ICD by doing different types of imaging? This has not been validated, but the finding of myocardial fibrosis on cardiac MRI may have some impact, because the myocardial fibrosis is the principal substrate for the basis of re-entry and the principal mechanism of ventricular arrhythmias in these patients. I would like to conclude. Basically what I have told already, the echocardiography is the cornerstone of diagnostic imaging in dilated cardiomyopathy, and the ultrasonic contrast improves the accuracy and reproducibility. 3D echocardiography allows LV measurements more accurate than 2D. The cardiac MRI is the gold standard to assess ventricular volumes and ejection fraction. CT and nuclear techniques are limited by the use of radiation, and coronary angiogram is recommended when the high likelihood of coronary artery disease is suspected. And late gadolinium enhancement cardiac MRI and CT angiography may be used in patients with low or intermediate risk likelihood of coronary artery disease. And cardiac MR is the imaging modality of choice in acquired dilated cardiomyopathy. Transthoracic echo provides several prognostic tools as I've described earlier, and the tissue Doppler and speckle tracking imaging provide prognostic information beyond ejection fraction. So detection of left ventricular contractile reserve at stress echocardiography is prognostically relevant, and identification of extent of myocardial fibrosis using late gadolinium enhancement cardiac MR predicts the sudden cardiac death or ventricular tachycardia. The echocardiographic parameters cannot be recommended to predict treatment response in CRT patients, and cardiac MR may be useful for stratifying the risk of sudden death of patients with dilated cardiomyopathy. So my references. Thank you very much for patient listening.
Anyone has any questions, please?
I have one. A very nice presentation. I consider cardiomyopathy. I used to work for heart transplantation, so I know a lot about cardiomyopathy. So what happens is it's a serious diagnosis, potentially serious diagnosis. People can die, you know. So now we are doing lots of tests, CT, angio, MRI, this and that. But if you don't do cardiac catheterization, you can miss most of a lot of things. You may have occult coronary artery disease. I know with a lot of calcification, your CT won't help you that much. You can have congenital heart disease. Unlike, Dr. Goodwin in England actually initially described cardiomyopathy, a primary myocardial disease, and you have ruled out congenital heart disease, valvular heart disease, coronary artery disease. Whatever happened to that decision, people confused it and muddied it. Because I think I do cardiac catheterization in every patient with a new onset cardiomyopathy because it's potentially dangerous, not to miss anything, not to miss anything. You should not miss anything. That should be corrected. So,
Yeah.
do you have to do cardiac catheterization? You don't do cardiac catheterization routinely in England. Number one. Number two, do you do myocardial biopsy to not to miss the amyloidosis or giant cell myocarditis, sarcoidosis, or things like that?
Yeah,
Okay.
non-invasive testing, actually, including CT, coronary angiogram, can miss a certain percentage of significant coronary artery disease. Actually, we can pick it up by only doing invasive coronary angiogram. So it's not always available, and whether it's worth taking the risk in patients who are actually very low risk of having ischemic heart disease. I don't know.
Okay, thank you, Dr. Rajapaksha. Ladies
Thank you
and
very
gentlemen,
much.